So yeah, it was just, gosh, it's been, I don't know, 2 or 3 years, I'm not sure, a couple of years maybe since we really started chatting to each other. And I remember, of course, we were all ploughing through the pandemic and busily trying to return to some semblance of normal practice. And I think you reached out to me on LinkedIn, which is a little bit unusual because normally consultants don't do it. It's normally the other way around. So that was an honor and a pleasure. And
no, not really. The thing is, I see so many patients who have this overlap of chronic pain, and then they have this need that someone needs to work with them with a combination of understanding their background, but also be willing to, do some manual work, or at least do some work that requires more than just the NHS normal of 2 or 3 sessions and a piece of paper and discharge. And I'd heard somebody, I think one of my patients, actually saying that they really had a good experience with you, and that was someone who understood the trauma bit. And for me, that was a real game changer, because I do not know still, even though it's now been a couple of years since we've met each other, I still don't know of too many physios and other colleagues in our local area, Berkshire, who are interested and doing the work that you're doing. This confluence and this intersection between physical therapy, emotional work, somatic work, the kind of somatic experiencing and tracking, which I was reading in the pain domain, and finding that there's actually a kindred spirit not too far away. That's always a nice thing to reach out to.
well, likewise, and to actually have pain consultants and colleagues in the hospitals locally who were also trauma informed. I don't really like that expression, but it's the one we're using right now. Aware, what you more eloquently described there, that intersection and a more holistic view of pain, of illness, of wellness, of health, disease, autoimmune disease, all of that. And to have somebody who wasn't going to think that was just all nonsense in the area was also really nice. And I recall our conversation and the chit chat and your kind of comments of, oh wow, well, we could be talking here all night, and we did about 3 hours, and went, we've got to go home and eat something now. So, but it just felt easy, didn't it? It felt like kindred spirits. Again, it can feel like a small world sometimes when everybody else out there is still stuck in the old paradigms, and you can feel quite lonely at times. I think it could be for me anyway. So
I think it's great to have that kind of presence here. Like, for example, I knew about this organization called SERPA. So I knew that there were physiotherapy colleagues, other allied healthcare professionals who were doing this work, but not many in the local area. And I think the second time we caught up again, probably in an informal setting, was that conference last year. It was a SERPA conference in June 2023, I think, in central London and Royal College there. And again, it was really great to sort of be part of that conversation, to find out that there is so much interest. But more importantly, I think that movement is now increasingly post-pandemic. That's another big advantage, that kind of connection is now being accepted. It was as if somehow in mainstream medicine, particularly, that connection between mind and body, the connection between the physical work and the work that you were doing as being increasingly relevant and important, is only now, I think, being appreciated in the mainstream last 2-3 years, and certainly after the pandemic with long COVID and other appreciation of how traumatic the whole journey of COVID has been for the population. I think it's only more relevant what you're doing and what we both are trying to do in terms of talking about all the issues that up to now used to be separated into silos, isn't it? Yeah. Somebody deals with that, somebody deals with this. We only deal with this.
Yes, I think and I remember the thread actually a little bit of our original conversation on LinkedIn, and I was sort of dipping my toe in the water, just going, okay, how far can I go with this chap? And I recall saying something along the lines of, I have a bit of a theory, because of course, well, we were only a year into COVID, and I said, I have a bit of a theory, because it was just as I've always done in my clinical practice, I think it's about observation and just seeing patterns and kind of going, I wonder. That I was just noticing patterns in patients, and I was going, I'm not a big fan of labels. They're useful, but also get in the way. And there's a lot of similarities between fibromyalgia, chronic pain, chronic fatigue, ME, and long COVID. And I just thought, and where I'd got to in my own clinical journey about those other issues was they were largely nervous system dysregulation, they were mind-body issues, they were linked to ACE scores, childhood developmental, neurological developmental patterns of how the body processes things within the body, and linking it also the PNIE system, psychoneuroimmuno and endocrine system being interrelated. And so I think I said to you, and you said, yeah, okay. And I said, my view is if the nervous system's not already dysregulated before the COVID lands upon the person, they don't get long COVID. And you went, I tend to agree, we need to have a chat. So we did. And then here we are another couple of years on, and largely the research is pointing to the fact that if you don't already have some kind of upregulation and dysregulation within the autonomic nervous system and central nervous system, you're probably not likely to get long COVID.
I think you're right. It's in terms of spectrum of risk, I think that risk is so much more magnified when there is a prior vulnerability in your nervous system, in your immune system. I think both those are definitely well-established facts now. If you look at the data that's come out and what the research is pointing to, it shows that these group of patients who have prior vulnerabilities in their immune and nervous system, you're right, that shows that. It's surprising, and I think that's where some of the work that we both are doing has importance, I feel, because there is also this group of people who apparently don't seem to have any such abnormality prior, and they are being affected either by the infection or worse still now, rarely, because of the vaccine. And both of that means that the system is dysregulated. They also need the same rehabilitation, they need the same level of support. And I think, if anything, maybe this is something I don't know whether the research is there or not, but my heuristic would be is that if there is prior vulnerability, it probably gets dysregulated a lot. If there isn't a prior vulnerability and it gets dysregulated, I think the chances of successful outcome and recovery are probably higher in these people because they don't have that added vulnerability baggage to overcome. Because you can only take them to a baseline, and if there was already a vulnerability baseline, that's more harder, I think, rather than someone who's otherwise been, in inverted commas, fit and healthy.
I agree. And just listening to you there, my mind has gone, is it that they have no prior, or is it that we're just not good at detecting or assessing or evaluating those individuals enough? Yes, I know you screen for ACE scores, which is, wonderful, because a lot of physicians seem to know much about it. And again, the data is pretty robust on that. And again, it's amazing, isn't it, how it's taken us to a pandemic to really start the populace really getting to know about this, when that work is quite old material.
Almost coming close to 30 years
now.
Yeah,
exactly.
First time the paper came out was 96.
Exactly, it's 96, isn't it? Mid-90s. So, and you think, well, how has it taken so long? And my wife's in education, as you know, and it's certainly, I think it's hitting education more than it's hitting medicine, actually, in terms of detecting these things. But I wonder, those are those very frank things that we see as the 10 markers within ACE scores. I wonder, thinking of my own work, where I could probably find many, many patients who don't have anything that would really fall into an ACE score, maybe don't really have anything that would be detectable as autonomic nervous system dysregulation, central sensitization, anything like that. But actually, when you go through the work with them over time, then more from, say, a psychological point of view, attachment, trauma, neurodevelopmental, that's under the radar, I just wonder if these people that you were just talking about might be somewhere in that category.
It's possible, very likely. It's just that at the end of the day, you're right about the ACE part, but for the long COVID patients that come to my clinic, we don't offer an ACE score for them. That's for the chronic pain service there. Okay. So for example, with specifically long COVID, or for example, in the community where a lot of the initial fibromyalgia patients get seen, they don't get given an ACE score there. Then we are entirely dependent upon what narrative they give, what story they say. And if in their story they choose to leave out this part here, and I think I'm always very mindful, and yes, I have physios and psychologists who sometimes do this multidisciplinary first assessments. It's still very much the patient narrative, and if they in the first consultation don't feel ready enough, or maybe rapport doesn't get established the first time around, they may not want to talk about that, what you actually say, what's under the radar, or what may be they think is not really relevant to the whole pain that they are coming with. Then that's not something that's going to come out on the first consultation. It may come out as you do more work with them. That may come out and you become aware that there actually was a pattern, a baseline vulnerability that they weren't aware of and you were not aware of, but then that comes through on future consultations. It's like the typical Donald Rumsfeld, the unknown unknowns. They are going to be unknowable until they happen.
And I think we're and the knowable, and if we segue slightly into more the kind of the body psychotherapy side of things, contact, touch, a somatic experience, being aware of our gut, and at a felt sense, and never mind a gut microbiome or anything else which is being communicated. Often these people don't know, and we spend too much time thinking that we get it. And some of this attachment stuff, of course, is happening at a time in our lives that we're probably not going to have any conscious memory of anyway.
Exactly.
And so these are systems, forks in the road that our nervous system has developed through life. No one gets through life without trauma. I mean, it exists for us all in a way. It's just how it plays out, or if it plays out. Yeah. And it plays out in all of our relationships through transference. It doesn't, it can't not, but does it create a problem for us? Well, yes or no. I think it's also interesting to explore the notion that we might not know it cognitively, but to go to the body's wisdom, if you like. And it's amazing when you work somatically to see how, if you slow things down, because often thought, it's what I call skimming stones strategy. It's the hyper-logicalized people, when they're finding something difficult, may use a dissociative strategy of talking or thinking very, very fast, like skimming a stone across the surface of the water, so it doesn't sink and penetrate. And that's a coping strategy too. And so, of course, they're not going to sink into the pain of what was really underneath. That's the whole point. They're avoiding it, so they're not going to understand that.
No, I completely understand.
Hi, I'm Rodger. Thanks for watching the video. Hope you enjoyed it. And don't forget to hit the like and subscribe buttons.
I completely understand. Your logic and your analogy actually reminds me of this. I was just reading and becoming a little bit more familiar with IFS. So the internal family systems there. And I really like the analogy of, you have the self, and if you can never really get in touch with the self, because right from the outset, from the time you're growing up, you have the manager or the firefighter taking over, deciding where the exile should be, then there's never an opportunity for the self to even come up to the surface. And your analogy made me think of that. That skimming the stones means that the manager's already gotten there and decided this is going to be the coping strategy. You really never get a chance to let yourself emerge from there. I think we have so much work to do in helping our patients understand their. It makes me think that now with the way the NHS and the way we work, whether I do private work, you're also in the private sector there, the big challenge for us, I feel, is how do we get the people to understand where they should be looking at the body themselves. The research is there, the cognitive work. If people want facts and logic, we've got enough now facts and logic to say that what we thought of as pain, for example, or for that matter, consciousness, doesn't entirely reside in the brain. As far as the brain, or as far as these aspects are concerned, we now are willing to accept, and hopefully the facts are there to say that consciousness is a body-wide, is a distributed phenomenon. It's actually an extension not just in the brain, but it extends to the body. And a lot of what we think are emotions that are strictly the preserve of certain neural circuits are still transferred into the body and manifested through the body, or stored in the body if you would like it, depending on which author you read. So the work that we do has got to take the whole mind and body together. And I think we have the facts. Its question is, how do we get past the emotional barriers of the people to actually make them aware that there is a reason for engaging with the body and the mind. And as yet we don't have, at least in pain medicine, which is my sort of wheelhouse, I can say that there's no drug that's ever going to achieve that. And there's no injection that I can ever do to achieve that. Though I must say I'm partial to psychedelics. Now, that might show something in the next 10, 20 years, but I think, sorry, I interrupt you, yes.
Psilocybin or...
Psilocybin, yes.
Yeah. Well, isn't that part of this is the cultural, there's a cultural evolution, I think, and a cultural paradigm that we find ourselves in right now. Hence the conversation, really, and how do we help people? Well, I guess that's why we feel both passionately about this subject, and we're trying to get the news out there and to everyone, our patients and clients, and also to our medical peers. Along my journey, as you might know, I've been a Zen student and somewhat of a philosopher for 20 years, and the consciousness, whatever is consciousness. And in fact, I was doing a video only recently, and we were talking about the mind-body medicine and mental health. And we'll go, well, years ago, we've got mental health problems, and we had huge kind of issues of guilt almost around having that, and so it wasn't spoken of. But we have mental health in the same way as we have physical health. It's just, how is it? And then saying, well, but then as you're talking there, I think you're right. It's been years since I considered mind to be contained in the brain. And now the science is backing up what actually the Chinese have been talking about for thousands of years. They talked about the upper, the middle, and the lower jiao as energy centers over and here we are going, there's a nervous center around the heart, around the gut, and around the brain, and they're of equal importance in a way. And so I think, what is mind? We talk about the mind and body. Almost we're perpetuating the Cartesian split once again. We're talking about brain and body, but we're talking about mind and mindfulness. What is it to be mindful? Well, is to be aware. And I like Peter Levine's experience, somatic experience. What is your experience right now? And to the question that you're saying, how do we help people to understand this? I think that's the skill of the therapist or clinician to be able to slowly guide them. And we must also be respectful, I think, as clinicians and therapists to go, that's the paradigm they've grown up in. That's the culture they have grown up in, is one that the mind and the body, and that physical pain is entirely different to emotional pain, which you and I know is not even quantifiable, that we can't tell the difference between the two. There's, yes, nociceptive pain, it is different, but can we perceive it? Well, no. And helping people to really understand the power, and I think analogies of life experience, where, we go, well, what is heartache? What is the devastation of grief? Well, that's a very real pain. People think, yes, but what about my shoulder? And well, yes, that could just be, it could be emotional pain, but it can also be, so for example, I have some patients I work with Tourette's type problems or PTSD, where we might see that as an incomplete motor response. So if somebody is being attacked, for example, the natural mechanism might be one of defense, but if in an assault situation, that might be thwarted because we feel we might suffer more if we are to defend ourselves, or even to say no or something to a parent or a caregiver, then we suppress that. And what can happen is that it's like the body is trying to complete that, but as soon as that pattern comes back up again, it gets suppressed again. Yeah. And so if the sudden tick and movement is really the body trying to complete an incomplete motor pattern. So the skill really in all of that is, I think, for us as therapists to be able, they're not going to work that one out. They're not going to work that out on themselves. That's our job, to help them to maybe slowly see the analogies of that. Can you see how that motor pattern might create some perpetual tension, and that's a tight muscle that's creating some pain, which is what's causing the chronic headaches and so on. And we can try and release that muscle off with manipulation and manual therapy, but it will come back unless we look to the real roots of the problem, I think. So it's our job to help, whether that be in that situation or helping people to understand their experience that we might call pain.
I think that brings a very important part there, isn't it? You mentioned, and I sort of briefly alluded when you talk about the body part, the body's role actually. You mentioned a few times, those kind of, for example, Tourette's. I would have never really thought that those kind of tick-based movements, and the way you explained it is so fascinating, and actually on reflection, that seems so much more logical than just assuming that that's how neurally it's left and that's what people have, trying to think of it as something that the body is trying to complete but is just left unresolved. Almost you argue a case there for more or appropriate use of manual therapy when needed, isn't it? Is that almost, and that is probably a little different to what I see in the NHS now, wherein a lot of times physiotherapy, there's very little touch.
True. I mean, manual therapy might, and touch. I almost want to move the language away from manual therapy to the use of touch, which of course, I don't know. I mean, I'm happy with manual therapy, but really, how does touch therapy, manual therapy is just language, really. And of course, that was my first discipline and primary discipline as a physical therapist. And I was trained in an era when we used a lot of touch. And it's being questioned a lot now. Increasingly, I don't touch, but not in the sense of using exercise alone as a substitute, as is often the case, to strengthen. Perfectly valid. We might need to do that. That's not most of my day-to-day clinical work. My team often are, yes, doing that kind of work. It might be, and I had a patient earlier, as I was just sharing with you before we started, where we spent the whole hour slowly working through something to where touch actually was he was able to accept, and then floods of tears and huge releases from his body, which is going back to childhood times. So touch can be very, very powerful, but actually knowing when not to, because we might instinctively want to go to support someone, but actually that could be quite triggering for a lot of people, could be quite difficult. So it's really the relationship and exploring this very delicate privilege, as I see it, to build a trust over time, to be granted the honor of the vulnerability in the therapeutic alliance, to allow and the trust to be seen, deeply, deeply, but touch can be so powerful. I mean, if we look at cultures around the world, touch has been used since time began to comfort people and to connect with people. And maybe looking back to COVID times, one of the things that became a stark reality was the absence of touch and human communication and connection. And I think more people working from home, I can tell you that whilst that has its benefits, gosh, we've become increasingly isolated at that time, and how we enjoyed coming back. So what is touch? What is it to be touched? And we can touch someone by our presence as well as our hands. And I think in this field, and overlapping in some studies I'm doing presently, some are psychotherapists coming more to bodywork, some are body workers coming more to psychotherapy, and realizing that perhaps they're not so aware of what's going on in the body, and perhaps we were not so aware of the psychological. And to be in this realm in the middle, I think is a space where many of us need to go, and I know you are, of course, in your own work. This is the space where we're joining mind and body.
I agree. So I'm right now narrating my audiobook. And so I had to do a little bit of work around all the therapies that I talk about in my book, including somatic tracking, experiencing, and then touch as well. And in part of the research there, and this is something I'm vaguely aware, but I just refreshed my knowledge again. So, Sapolsky, Robert Sapolsky. So he done this fantastic series of experiments on mammals and, why they do what they do, how they connected as a tribe. And if you take that starting point that, okay, we are social animals, we need connection, it's how we have as a tribe and as a social species thrived and flourished and become, if you like, the apex predator for this ecosystem that we live in. But touch is integral to all of that, because touch is one of the fundamental ways where you provide safety. We've got the aspect of knowing that a child, when it feels the mother's touch, is a release of oxytocin. There's data to say that if you hug someone for 10 or 20 seconds, that's enough oxytocin release. So, and Sapolsky talks about this fact that when primates and when chimpanzees get stressed, one of the things that they come back to, and he talks about their routine of older chimpanzee looking for nits or looking for something on the other chimpanzee, and they apparently used to wonder, why is this strange preoccupation with constantly looking for nits for a long period of time? And the explanation put forward there was that is their de-stressing routine. That's their autonomic regulation routine going on there, that when another chimpanzee or another primate is able to use touch, it's not that they are specifically achieving anything by picking out nits or cleaning their fur, but actually that is the extended period of touch and care that the other stressed out chimpanzee then feels that it can let go, because that trauma or stress or signaling has been processed because of this touch. And when I dictated and narrated my touch therapy thing, I realized maybe a lot of the way that we need to talk about, when you talked about this intersection of psychology and body work. Probably the intersection now is to a certain extent facilitated by neuroscience. The fact that we now know that when you touch, you are completing some circuits, you are building sometimes new circuits, you are allowing for certain neurochemicals, the neuroimmunoendocrinology that you talk about, you allow for those chemicals to be processed or washed or released appropriately. Is that how touch therapy is to be reframed? The fact that it's not that we are stretching muscles or doing something physical, that may be a byproduct, but probably the first thing is the feeling of safety, the feeling of autonomic regulation, the feeling that in somebody's hands, if it's a massage therapist that if it's a physio if it's somebody OT you finally can then just relax and allow for some processing. Thank you for watching the videos. I hope you're getting value from them. Don't forget to subscribe and hit the bell button for notifications on when the next videos are to be released.
I was chatting with a colleague earlier on saying we were going to be doing this talk, and years ago I've always challenged the principles of what we think we know and why we think it's working. I disagree fully, and I think that it's not supported in the evidence and the data to suggest that manual therapy is ineffective, because I think it's nonsense. There is good evidence for that. You just need to, certainly for low back pain, it needs to be applied soon enough and frequently enough. Now, often if they can't be seen for 6 weeks because that's the NHS, well, that's a different story. But to suggest that it doesn't is wrong. How it's working, now that's a different matter. And if we look at some of the other research out there, one of the greatest predictors of outcome for almost anything, even almost surgical intervention, as you're probably aware, is the relationship that you have with the treating clinician. There's some evidence for that. And I think we have to tie that in as well. Touch, of course, we can be present, and safety, and certainly that's a key tenet of any kind of somatic work, psychotherapeutic work. I mean, we've only got to think about holding the space and why. I was chatting earlier on to some of the work that I do. I know somebody who works as a sexual trauma therapist, and she says very clearly on her website, I will not work with anybody who is not prepared to do at least 2 years of work. Because you have to unpick this very, very carefully and sensitively. And it's about building the trust. You don't build trust overnight. You don't build that. And
you can break it overnight.
You can break it overnight. Yep. And I work with people, and I can say it could make me cry. It's an honor when they say, I had somebody recently say, I'm 95 to 99% able to be completely openly honest with you and about my emotions and feelings. 65% with my wife. And those are the only two people, and no one else gets anywhere close to either of those. Yeah. Well, what an honor that is. So safety is important, and at least it's a start point. Now, I think, yes, what are we doing with manual therapy? Can we generate safety in the nervous system through touch? Absolutely, I believe we can. We can also create lack of safety in the nervous system with inappropriate touch or a sense of lack of attunement to what the individual is needing right now.
Yeah, I love that word, attunement, that you use. Go on, yeah.
Yeah, well, that's harping off to Bowlby's attachment theory and an attuned parent. An attuned parent is what we need neurodevelopmentally for us to be able to feel safe. Yeah, is something's not right. I wake up in the night, I cry, somebody comes and they support that to create safety. But manual therapy, I think we do need to look at a difference between, say, acute situations, musculoskeletally, and chronic situations. Quite organically, over my career of 30 plus years, I have moved more and more to lighter touch techniques. I've explored I've studied craniosacral therapy, I've studied acupuncture and done less needling and now more touch. I've looked at energy medicine and being able to go, why am I feeling things in my own body and resonating things and being able to feel almost some kind of shift going on within the body away from areas of my hand that people would have thought was nuts years ago. Yeah. But we now have some greater understanding of, maybe whether that be fascial work, energy work, I don't mind and I don't care. But certainly lighter touch is, I think, somewhere we ought to be going. Gone are the days maybe that we're sticking elbows in people's muscles and creating more pain than beating 7 bells out of somebody. I'm not sure that that's where we should be going. And I would champion some questioning of that. Sometimes that deep work can be effective. I go, well, look, has it worked? Yes, it has, under my own hands. So this is the skill and the art, I think, of what we're doing, is knowing what to do just when.
Yeah, and I can draw a parallel sort of in my field now. There's so much pushback against medications and injections. It's something that I was exclusively trained on. My 1 year of fellowship in pain medicine was entirely about understanding and diving deep into what are the drugs. In fact, I heard recently, and it's something that of an eye-opener, apparently there are up to 200 medicines that can be used for pain. But there's just barely a few that have been officially licensed for pain. Everything else is what has been repurposed from other specialties, from cardiologists, from neurologists, from psychiatrists, and then been repurposed because they have some way of working on some parts of the pain system, as it were. But now we are executing a wholesale pushback against all medications, or at least the biggest ones that we know. We're also saying at the same time no to all the injections, or most of the injections, saying they don't seem to work. And I share the same sort of feeling as you said. I champion the fact that yes, there is no role for going higher and higher and higher on every drug, especially opioids, given what we now understand about them. There's no reason to keep doing injections every 2 weeks or 3 weeks of steroids, which used to be done and still being practiced in many parts of the UK by surgical colleagues of mine, by colleagues of mine, by other practitioners, saying, okay, you got an arthritis in your knee, so we'll do one here. Then 2 weeks later, you go in your hip, you got to do there, and then in your shoulder, and then pretty soon, in a 3-month period, I sometimes have patients who have had 4 or 5 steroid injections done by different specialists, and they come to me with about 5 big slugs of steroid given to them in 5 joints over the last 2 months, and I'm wondering, do I have my share of the stuff in the back? And I agree that that is a bit excessive. However, I'm also not prepared to throw the baby out with the bathwater, because there is still a value for some people in whom the medications keep them functional, keep them working, keep them at peace with themselves, because they are in a system which is not going to change. And if this drug or combination of drugs is keeping them functional, active, and a productive member of society without causing harm to their family or themselves, then that's a choice at least I feel I should be allowed to exercise. And the same with interventions. And I do worry that sometimes this excessive focus we do have these days on deprescribing or cutting down and decommissioning interventions is going to be counterproductive, because we haven't given patients an alternative framework for them to hang on to, and we haven't exercised enough nuance in saying, okay, for this person, maybe it's interventions and medications or manual therapy of some kind, rather than saying, you will not get anything. All you have to do is learn how to breathe and
And you're sorted.
And you're sorted. Or think different.
Yeah. Yes, exactly. Yeah. And gosh, if it were that simple, then actually, wouldn't it be so much easier and everyone would be fixed very quickly? I feel something as listening to you there about the art and the mastery of what we do, the craft of what we do, and the famous expression, the more and more you do, the more and more you know, the more and more you realize how little you know, and the more doors I open, the more it's like Alice in Wonderland, and realize there's an entire whole corridor full of more doors and more kind of magnificent worlds to explore. And some might say, well, gosh, doesn't that just sort of drown you in it? No, not if you've done it in the right way and you've paced yourself and you've explored it, and then it complements and expands and supports everything else. I think going back to the trend that exists within my primary domain of physiotherapy at the moment, that if you use your hands, you should be shot, and that it's
Wow,
bad.
that's dramatic.
Yep, it's literally, I even I dared to comment on something, a post recently where somebody said, so you're going to continue to treat patients with something which is not evidence-based purely in order to further your private practice financially. And I was like, it's nothing to do with that. It's not evidence-based. It is. Doesn't in life everything swing in trends, and the pendulum swings often too far, and I think, I don't know, maybe is it the lack of, it sounds arrogant perhaps, but the lack of mastery, the lack of artistry is where we then hook onto one thing and think that, okay, well, this is the way, and it is the way for all things. Okay, well, here's this wonder drug. Okay, we're going to give it to everybody. Here's this wonder injection. We're going to do that to everybody, and it works. Does a master craftsman who spent their life in apprenticeship and work have lots of tools? Yes, they probably do. Are they good because they have a lot of tools? Not necessarily. They know how to use a few of them very, very well. But what they also realize is those occasions when they go, that is the wrong tool for the job. And over here, we have this tool that very occasionally needs to come out. And I think that's what we do, whether that be in pharmacology, or whether it be in nutrition, the gut microbiome, understanding that, whether it be psychological elements, which is why I think we have to become more holistic. And yes, of course, I'm not a nutritionist, but we have to, I think, explore. And in fact, I think in one of your recent videos, I recall you saying, well, look, I think all of us need to be aware of the importance of nutrition as physicians in dealing, if we're anybody in the realm of pain, it was something like that I seem to recall you saying, needs to be aware of gut microbiomes. And so we must be aware of sleep. We must be aware of nutrition. We must be aware of those things, because what's the chicken, what's the egg? Arguably, we can do a whole bunch of somatic work, we can do a whole bunch of neurological work, psychological work, but if the gut microbiome is disturbed, then we're only going to get so far. But then we go, well, why was the gut microbiome disturbed in the first place? Was it antibiotics which did it? Or was that the dysregulation from the autonomic nervous system which then dysregulated it? And we're, chicken, egg, chicken, well, how long do we want to talk about that?
I don't think that is probably another, exactly as you said, another corridor, another door, another rabbit hole that you want to go down to. I probably reckon the way I think about it these days, and that's why I'm appreciative of the fact that we need more tools. For me, pain management, and for that matter, long-term condition management of any kind. I take a deep interest in lifestyle medicine. I know that there might be some of the listeners who might say, oh, what's lifestyle medicine? That seems like a term that feels like everything is about one person's lifestyle, and I appreciate there are challenges of that. But what I mean is that the attention to what can be used to calm the nervous and immune system, there are so many things that influence it. And for me, the simplest way to think about, or rather the complex way to think about it, is we are all in a complex system. And part of the characteristics, so this helps me sort of make sense of it in my world. And that way it helps me make sense every day of getting up and doing what I do, is I tell myself, well, you know what, I'm living in a complex system. To be more precise, what's called as a complex adaptive system. Every day I go to work, that is a complex adaptive system. The person who comes to meet me in the clinic is coming from another complex adaptive system. And what we understand up to now about a complex adaptive system is that each interaction can change something. Cause and effect are not related at all. So what I tend to do will not necessarily give the same result in that person this time or the next time, and there's no correlation at all. So for me to expect that someone is going to respond to a drug today as they did 6 months ago or 2 years later is not practical. And there will always be unintended and unexpected consequences of everything that I do. So the question therefore is, the opportunity there for me exists is that I can show each person, this is the menu of what's available to help you with. These are all the things that could make a difference for you now. And this is how I intend to help you. But each interaction to me matters. Each interaction makes a difference, because I might actually catch someone seeing me the 4th or 5th time, and a message that hasn't gone down 3 times before, today might be the day that the message descends, and all of a sudden it lands and the light bulb moment occurs and they're ready to engage or find something that's beneficial. So to me, that keeps me going to say that, you know what, I will never know really what's the one thing that cures this person, which combination of drug, injection, manual therapy technique, or diet or sleep. But the point is, that doesn't mean I shouldn't talk about any of them. My primary then focus as a practitioner is at least to be aware of all of them. I may have one expertise. In my case, it is drugs and injections and pain science education. But that doesn't mean I should be unaware of what you do, because I need to know when that person comes into my clinic room and says, I think I know what I need, where do I go? And I need to be able to say, I know there's Rodger there, go to him. And I feel confident that at least I've got you somewhere in a closer corner than what I had probably 2 years ago.
What I think you're describing there is a much more humble relationship, where I think, oh gosh, if we go back, then we used to do things to people. And I think now we're talking about being in this, what I call the therapeutic alliance, where we are working alongside with people. And in some respects, of course, we have a great understanding about various things, but actually, usually it's using those skills to help the body and the person help us to understand and to go into a relationship on a journey to understand and help explore and find ways for them to come out, so that we can then see what it is that we need to deliver or offer to them or for them. Yeah.